Graduated from the New York School, class of 1999. Did my residencies in New York and then came down to the Tampa, Florida area because that is where my parents were and I knew I could open up a private office here. So I am in private practice, but I have worked in the wound care arena at a wound care center in Town and Country in Tampa, Florida, and also for a new and emerging market, which is telemedicine. So there's a large telemedicine company here that does wound care, and I was able to be a part of that as well. I just need all my assistance to get this. Okay, so what I'm going to do today is go over some lower extremity ulcers that podiatrists commonly see. I know each state is different. Here in Florida, we're soft tissue up to the hip, so it is not uncommon to go into a hospital or acute setting where there are not as many doctors and the podiatrist is asked to look at bed sores until a plastic surgeon does come in. So for that reason, I did also include some pressure wounds. So as you know, our skin serves several functions, and it's very important, and that's why we want it to be healed. We don't want to have wounds. So the first is protection, also sensation, thermal regulation, body image, and immunoprocessing. As a podiatrist, the three wounds that we mostly focus on are venous leg ulcers, diabetic foot wounds, and pressure wounds. Pressure wounds here, their reported occurrence rate varies widely because as podiatrists and as other doctors see low grades of pressure wounds, they don't always document it. So you may have areas of non-blanchable erythema, but it's not documented. And so that is the area that we do need to work on because this is a very litigious society, and pressure wounds, especially in nursing homes and assisted living facilities, are becoming more and more of a big deal. And so they are requesting podiatrists to come in. So that is an opportunity for us to come in and look at these areas and say, that's a hammer toe, that's a bunion, it's non-blanchable erythema at the bony prominence. It could become a callus, but it could also become an ulcer. And that's why we need to offload it, and the instructions on how to manage it needs to be given by a podiatrist. And that's why as podiatrists, we are of value to your facility. Not only do we come in and cut nails and calluses, but we also look for the beginning stages of a pressure ulcer, and we will relieve that pressure for you. As in diabetic foot ulcers, we are definitely an important part of the team there because about 15% of all diabetics will develop an ulcer, and even if they're able to get it healed, there is a high reoccurrence rate. So a change in shoe gear, lifestyle, all of those are important in order for them to not redevelop this wound, because most diabetic foot ulcers are responsible for more than half of the diabetes-related amputations. Some states podiatrists do not really work with venous leg ulcers, but we do here in Florida. The challenge we have is that this is a very warm state, so it's hard to get people to want to be in a Una boot or a total contact cast or certain shoes and things like that. So we do have to be pretty creative with our treatment management. But you do see that you have a large obese population with venous insufficiency, and they do have leg ulcers. Another issue is that it's very visible. When you have a diabetic foot ulcer, a lot of time it's on the plantar aspect of the foot, and it's easier to cover here in Florida. But if you have a venous leg ulcer, that people are able to see that, and so that affects the psyche of the patient a lot more. So it's about 1% of the general population and about 3 to 5% of those older than 65. And of course, we have a lot of elderly patients here in Florida. The reoccurrence rate is now at about 70%, which is very disappointing because we know how to basically keep that from happening again. So the patients are either not really taking our advice under adherence, or there's some issue that number is really high and it needs to come down. So back to your days of schooling, you have 4 phases of wound healing. When I was in school, we only had 3, but now they do include hemostasis, which is immediately after injury where the body is going to form a clot. Then you have inflammation where the area gets red and the leukocytes and macrophages infiltrate the wound site, lasting after 4 to 6 days. This is the stage that a lot of doctors have some difference of opinion in when it comes to wound care, and even post-op wounds where you're given an anti-inflammatory. They're always questioning, do we intervene in this process or allow it to move forward into the proliferation stage where you have granulation tissue, and that normally lasts for several weeks. And the last stage is maturation, where you're going to develop that strength of the wound and hopefully it will not reopen. So you have many factors that affect wound healing, and in this lecture I will include things that are not just podiatry specific, since there are other doctors that are part of the conference. So you will see that locally the factors are desiccation, infection, maceration, necrosis, pressure, trauma, and edema. Systemic, body type, chronic diseases like diabetes, immunosuppressant like HIV, nutritional status, very much underestimated, not very well researched and documented in our field. But we do have a lot of up and coming studies, especially at the University of Texas, where they are showing that things like vitamin C is able to be one of effective treatment for sepsis. So, we know that if we do not take care of these wounds and they're at the point where the patient does not want to have an amputation, or they're delaying that, and sepsis is maybe an issue for us, we know that we can give the vitamin C combination to hopefully ward that off. And there's been some evidence that that is a very effective treatment. Also, with the nutritional status, we want to check albumin, things like that, and vitamin B levels. And your vascular insufficiency, you want to make sure your pulses are good. So now the wound healing complications, like I said, there are things on this list that we don't normally see as a podiatrist. Maybe a general surgeon would see fistula and more or less hemorrhage, but we do see dehiscence and we do see infection a lot. Now, this is a wound healing and hyperbaric oxygen clinical pathway. And what you'll find is that it's just a basic algorithm. So here in Florida, where there are large companies that control the wound care centers, and when you are hired to work at a wound care center, they want all the doctors to basically manage the patients in a similar pattern. So everybody is following the same algorithm pretty much. With telemedicine, you have more of an independent consultation that they're expecting your expertise, so you don't necessarily have to follow the same clinical pathway. But if you're in an employment situation, you should basically be looking to see what kind of algorithm that you want to follow. And this is the algorithm that I follow, and it starts off with a patient assessment. There's a history and physical that comes from the physician, may it be the internist, may it be the podiatrist, and there's also a nurse assessment who does the vitals and maybe also play a little bit of social worker. And the first thing you want to do is assess the tissue oxygenation. You can test the macro circulation and micro circulation. So you want to check your pulses, and you want to see your tributaries into the toes. Second, you want to assess the venous stasis. So you want to see any clinical presentation of venous disease, whether that be edema, varicose veins, things along those lines. Next is soft tissue infection. So you want to see your local signs, with pain being your fifth sign, but you want to see erythema, calor, any pus, and things like that, and if a wound culture is necessary. The only issues that you have with taking cultures in wounds is there's a difference between a wound being colonized, contaminated, and infected, and I'll go over that later. Also, you want to see if there's any obvious signs for osteomyelitis, so if there's any bone exposed or if you can probe to bone, and I will go into more depth as to the way you do probe for bone. Secondly, you want to assess for pressure. You want to find ways that you can offload any bony prominences or just wherever this ulcer has developed. In the case of pressure ulcers and diabetic foot ulcers, you definitely want to find ways to offload those. Lastly, but very important, is you want to assess for malignancy. If you have a wound that this person has been going from doctor to doctor to doctor with no success, you want to document how long they've been at each doctor before they got to you. Because just because you've had a wound for 2 weeks doesn't mean that this person hasn't had a wound for 3 months. And if they've had a wound from anywhere to 3 to 6 months, you definitely want to check for malignancy, so you want to take a biopsy. Also, you want to assess for necrotic tissue, whether you're going to debride this wound mechanically, autolytically, enzymatically. You want to find out what you're going to do with the debridement of the necrotic tissue. And lastly, you want to assess for the ability for this person to receive hyperbaric oxygen, which also brings you back to the first assessment of tissue oxygenation. It's not enough for the blood to be circulating. You need the blood to be oxygen rich and circulating. And so there's different things that I'll go over later with the hyperbaric and ways that is, you select patients for that. So first and most important, when dealing with a person who comes into your office and has a wound, is documentation. You must document, and you must be thorough with your documentation. And there's never too much documentation, but there's definitely too little documentation. And like I said, this is a litigious society, so if you do not have things documented properly, it's not going to end well for you. So the first thing is you want to know the chief complaint. What type of ulcer is it? Is it diabetic foot, pressure, or venous? Then you want to know the history, how long this has been going on. Like I said, if it's been going on for 3 to 6 months, then you would like to know whether you need to check for malignancy. You want to know the medical, family, and social history. There are differential diagnoses in lower extremity wounds, so so family history is really important, because you can have patients with like sickle cell or Raynaud's or different things like that, and you need to know that history. So in a lot of cases, it'll get you closer to receiving hyperbaric oxygen a lot quicker. Also, the social history is important. You need to know if they're smokers, things along those lines. Review of systems just basically tells you anything do they have heart problems, do they have diabetes, things like that. Physical assessment is going to be the assessment of the wounds itself, and those will be gone over later in the presentation. Risk assessment is one of the more up-and-coming areas that podiatry is being asked to do more and more. And this is the risk assessment for pressure ulcers or even diabetic foot ulcers. There's an area that's up and coming, it's called geriatric podiatry. And in that assessment, we're looking for whether they're going to fall, if their shoes are appropriate, and what are their chances of developing a pressure ulcer. And the stronger you get in this area, the better chances you have of gaining employment, whether it's with a nursing home or wound care situation. Procedures forms, or whether you do a biopsy, debridement, those things, supplies, anything you give to the patient in your private office. Dressings can be billed for. If you're doing home health, they cannot be billed for. So those are just extra things you would like to know as far as supplies. And your test or your laboratory test, we did talk about that as well. Patient and caregiver education provided. This area is very important because when it comes to the point of if this person receives an amputation, they 9 out of 10 times say that they did not know that risk was there, or that the things that you told them to continue taking that antibiotic, to remain non-weight bearing. Those are things that they somehow forget to do. So they are non-compliance. They a lot of times say doctors didn't tell them. So you want to document that not only did you tell the patient, but you gave instructions to their caregiver as well. And a lot of doctors have certain things printed out, so they just automatically hand those over to the patient. The care plan, CMS is looking at this a lot more. You get points for having a care plan in the chart. So your care plan is to be documented as to what needs to be done weekly and when you expect the wound to be healed. And the discharge plan is basically giving the patient the instructions so that they will not be in a position for this wound to reoccur. So in God we trust, everyone else must show data. So these are just things that you must do for the wound that can be duplicated by any other person. So you want to do like your Doppler studies, and these are different instruments you want to have in your office or in your possession so that you can do it if a wound happens to come in. You can have your Doppler. Years ago, these handheld Dopplers were reimbursable by CMS. At this point, you need to have one where you can actually print out the results and attach that to the chart if you'd like to get reimbursed for that. Also, you have your stem Weinsteins, you have your tuning forks, and your cotton swabs. So in diabetic foot, you want to test for neuropathy, and you want to also make sure that that neuropathy is due to diabetes. I mean, I've had patients who had neuropathy from past tuberculin tests, alcohol, just a lot of different issues. So you want to, be proactive in getting your history so that you are documenting that properly. It's consistent using a monofilament. If you use it and someone else uses it, the results should be pretty much the same. You have 10 areas to test, and if there's any loss of protected sensation, that gives you a good estimation as to whether a wound will develop or if there are areas that you do need to offload. You do need to take some care when testing these areas because patients will often just say, yes, I feel it, yes, I feel it. So every once in a while, you need to not touch them and ask them if they feel it just to make sure that they are giving you the correct answer. Okay, so when you are using your cotton swabs to check the depth of a wound to see if the bone is exposed, you want to document it in a clock-like situation. So this picture is actually rotated a little bit off. The center will be 1, and it'll go 2, 3, all the way back around to 12. And you are documenting the number of the deepest area of tunneling, and if you have an area where it probes the bone. Also, you are documenting the width and the length of the wounds. and you can use that. A lot of us have these disposable rulers where you put the patient's name on the ruler and you take a picture of it and you just show in centimeters the length and the width. Now, there are two systems that we use to document most commonly. There's also the University of Texas, which I will get into later, but these are the two most common. You have the stages for pressure ulcers, and you have the grades for a diabetic foot. So for pressure ulcers, like I said, podiatrists, we have to be more proactive in documenting stage 1, because that shows why we are necessary. You know, you have non-blanchable erythematous skin, and we come in and we see that, and immediately we know to offload the patient. So, but if you see that stage 1 and you don't document it and you don't say anything until it becomes stage 2, then, you know, our role is not valued as much. It's being reactive instead of proactive. Also, in Wagner, there's a grade 0, which is pretty much the same. So you have in Wagner, you have your grade 1, which is superficial, grade 2, which is deep to tending a bone, grade 3, which is abscess or osteo, grade 4, which is gangrene of the forefoot and gangrene of the forefoot, and grade 5, which is gangrene of the entire foot. The pressure system, stage 1 is that non-blanchable erythema, stage 2 is partial thickness, stage 3 is full thickness, and stage 4 is full thickness with extensive necrosis. And here are just some pictures of different stages. In this second picture here, where you see the toe, a lot of podiatrists will see a fissure or an area of erythema and not document it until it becomes this level. That's not what we're supposed to be doing. We're supposed to definitely document and let the facilities know there's an issue here, I'm treating it, and I'm making sure that it doesn't develop into an open wound and keeping you from being sued. Okay, so the University of Texas diabetic foot classification, the reason that this one is different is because not only does it include whether the wound is superficial or deep, it includes whether it's infected, ischemic, or both. And that's a very good indicator of what it's going to take for this wound to heal, you know, or if this wound is going to heal at all. So that is why this system is used, but it is not as commonly known in this particular area as the Wagner. Also, we have the C classification of venous disease, where C stands for clinical signs, E stands for etiology, A stands for anatomic distribution, and P stands for pathological condition. Okay, so with the venous disease, the C classification system, and this is what we use when dealing with venous stasis ulcer or venous stasis disease. We're looking at class 0, where there is no visible sign, which that is pretty much different than the foot ulcers and the pressure ulcers. The very first class shows a visible sign. In venous disease, class 0 shows no visible sign. Class 1, you have telangiectasias. Class 2, varicose veins. Class 3, edema without skin changes. So when you're evaluating a patient and they have edema, you're not just writing edema in the chart. You're writing C classification 3 of venous disease. So you're documenting that, yes, I see this person has venous disease, and this is the classification of it. Because other than that, edema can come from the kidneys, can come from the liver, can come from a lot of other issues. You can have an acute injury, and that can give you edema. So when you're just writing edema in the chart, that's not really giving us enough information. Class 4 is skin changes with venous disease. Class 5 is skin changes with a heel ulceration. And class 6 is skin changes with active ulceration. So this is just a little cartoon that shows you, why the tools that are given to you, they're just used as a guideline. They're not the end all be all, but they're a good guide to get yourself situated if you do have a wound that walks into your office and you don't commonly treat wounds. Also, you want to use a multidisciplinary approach, which means you want to get a list of your referrals in your area. So it's not enough for you to just know the vascular surgeon that you have lunch with. You need to know the vascular surgeon who likes to revascularize blood vessels into the toes, things like that. So, because there are differences between each specialty, what doctors like to do. So you need to have a referral base of doctors that like to treat the conditions that you see. Also, you want to utilize patient case reviews. So whether that is patients that you've seen retroactively going back into the chart and seeing what you've done that worked, and also looking at the latest studies and seeing what people across the country are doing that works, or in other countries that are doing that works. So once again, we have the algorithm here, and after the evaluation stage, what you can observe acutely, we're going to go into non-invasive and invasive studies, and then later on treatments. So like I said, you need a multidisciplinary team. We as podiatrists, in a lot of cases, even if you do routine foot care, you are going to be the first one that the patient comes to with a wound. So you need to know how to treat that on the foot. You also need to contact the internists because they are going to manage the disease. If your patient has a hemoglobin A1C of 11, it's, you can do, all you can do to that foot is not really going to heal because they're not being managed properly from a systemic point of view. General surgeon, you're going to always do what you can, but there will be times that you need to, maybe do an amputation above the level that a podiatrist does. So you may need a general surgeon in that event. There also may be things that you want to try to use as far as limb salvage in the patient, but you may be in a state where you don't have that area of scope, but you do have the expertise. What you can do is bring in a general surgeon and you can work simultaneously. So my general surgeon happened to be my chief, and we've worked several cases together with the vascular surgeon, the orthopedic surgeon, the general surgeon, and myself as a podiatrist. There's all 4 surgeons in the room because we would have patients who have ulcers from their butt to their toes. And so we all go into the operating room together, and we work on our individual portions, but we work as a team. We don't bring the patient into the OR 4 separate times for multiple wounds. We all go into the OR together. Plastic surgeons, they come in where you want to do your rotational grafts and things like that. Sometimes podiatrists do them well. Other times it's better to call a plastic surgeon, because in my experience, my wound, a rotational graft for me fails where I need it the most. So I, love calling in a plastic surgeon who can help me with that. Orthopedic surgeon, a lot of times you'll have hardware that needs to be removed. It may be a little bit difficult for you to do so, and you can bring them in. Infectious disease is very good, especially if you're in a hospital situation, because different antibiotics cost a different amount, and they are very good with getting that cost control. Also, they are very good as a backup where you may need more than, every podiatrist knows a good 5 to 10 antibiotics that they commonly use. They have more of an arsenal. I've had a few patients who have become septic, and regardless of what tests we ran and antibiotics we give, we were unable to save them. And so having infectious disease involved in the case basically was a double protection for me from a legal standpoint. Vascular surgeon, you always will need somebody to revascularize the foot. So like I said, you want to find someone who focuses on digits and things of that nature, not just the lower extremity, because if you run into trouble, those are the guys that will bail you out. Hyperbaric physician is someone who's going to look at the patient and say, not just a financial standpoint that they will be a good candidate, but a good candidate based on what their foot actually looks like. Endocrinologists, there are a lot of diabetics and patients who have different systemic diseases that are just extremely hard to manage. We know them as brittle diabetics, so it's always good to have your endocrinologist on board. The endocrinologist that I work with the most, I'm sure she's probably at this meeting, and she's very good about, once the patient is in the hospital, getting them under control and then calling me as a podiatry consult to come in. And every time I have a diabetic foot that comes into the hospital, I call the endocrinologist on board as well. Certified diabetes education, you always want to have someone, especially if your patient is admitted to the hospital, who can give them handouts, who have 1-800 numbers, who have websites, all those things where the patient can look back later after your visit with them and get more information. Because like I said, when you're in that process and you're talking to the patients, they pretty much don't retain the knowledge. Pharmacists, they will help you as far as making sure you have things that work together properly, and if there's something that they think is better, they work kind of in conjunction with the infectious disease doctors, whether you have the proper price control and things along those lines. Psychiatry is the managing a diabetic foot ulcer or pressure ulcer or a venous stasis ulcer is very draining on the psyche of most of our patients. It's an ongoing process, and they're at threat for loss of limb, and so it is very hard on your psyche. They often have to change their lifestyle, maybe stop smoking, maybe lose weight, and those are things that are difficult for them to do, and they may need the aid of a psychiatrist, and they may also, you may also find a lot of your patients, if you're in a nursing home and you're seeing some of these patients, they will have failure to thrive, and so you will have to call in the psychiatrist as well. Rheumatologists, I don't use as often, but there have been some cases where you have patients with gouty tophi that will ulcerate, and so there are a lot of new drugs that are working on gout crystals that are dissolving them without you having to take the person to the operating room, and the rheumatologists are very good with these medications, so they're a very good consult to have on board. Physiatrists and physical therapists work together to get the patient back in motion after you put them in whatever type of shoe you need to put them in. Registered nurse is somebody that they can call and talk to, who can explain things in a way that they can understand it a lot better than you can sometimes as a doctor, and that they do not feel intimidated to tell the truth to. So it's always good to have one on board. Registered dietitian basically goes over nutritional things with the patient. Always good to have. Orthotist and podiatrist pretty much can do the same thing, but if you have a high patient load, you may want to refer to an orthotist who pretty much focuses on the diabetic shoes and things along those lines. Social worker comes in when it's time to basically, there are things, whether the patient might not be able to afford to continue to take days off from work to come to your office. They may not have transportation to come to your office. Some patients have Medicaid and they get a transportation and it takes them all day to come to your office and be transported back home. So there are things that the social worker can help them with that you as a doctor just don't have the time or resources to. So in the first step of assessing tissue oxygenation, there are non-invasive and invasive studies. You have your Dopplers, your ABIs, your toe pressures, that's non-invasive. You have your arteriograms, CTA, MRAs, that's invasive. Revascularizations, you have your arthrectomies, your bypass, your endovasculars. Those are for your Silverhawks and such. those are the vascular surgeons that you want to know, the ones who do perform those procedures. And for non-reconstructive, you can always evaluate for hyperbaric oxygen. The main barrier to hyperbaric oxygen is pretty much insurance. With assessing the venous stasis, you want to look at chronic edema, hyperpigmentation, varicose veins, and such. You can do your venous duplex scan, which is non-invasive, and if you rule out DVT, you can also bring in compression therapy, which, as long as you have something that is at 30 to 40 milligrams of mercury, you should have good compression. But this is also contraindicated in ischemic extremities, so you definitely want to check for that. Okay, now with your soft tissue infection, you want to do tissue cultures, swab cultures, and aspirations. Those are 3 things you want to document if you believe the patient is truly infected. When you send these off to the lab, they will give you a tissue, they will give you a bacterial count, so you will be able to see if the patient is colonized or actually infected. Now you also, if you have some positive cultures, you have topical antibiotics that you can mix together. You can also get the patient systemic antibiotics. I would also add, like I said, there are new studies on the vitamin C, which is good for sepsis, so you can also throw that on board. You also want to assess for gangrene and necrotizing infection. For osteomyelitis, you want to see if there's any exposed bone or if there's any probe to bone or any tunneling over a wound. Once again, when you document the tunneling, you want to put the cotton swab in and you want to document the area of the largest tunneling, and you want to document that as a face of the clock. Also, you want to use your x-ray as first line, MRI or bone cultures to rule out osteo. So in acute osteo, you can do surgical debridement. You can add your antibiotic beads, things along those lines. I believe they say the beads are 20 times as effective locally as systemic antibiotics. So for a long time, I would put in my Vanco impregnated beads, and the infectious disease would still hit them with Vanco. And then I had a couple of patients who had issues, would get readmitted with issues with the kidney. So eventually my infectious disease doctor stopped giving them the Vanco if I put the impregnated beads into the foot, and that would work out very well. You also want to assess for pressure. You want to do your off weight bearing devices such as crutches and wheelchair. This is where your physiatrist comes in, because you want someone who is going to actually sit down and explain to them the proper way to use crutches, and measure them properly, or whether they should be in a wheelchair because they just don't have the wherewithal to walk in crutches. And you want to make sure your shoes are that you pick the right offloading shoes. Some offloading shoes. We have the generic diabetic shoes, which every year the requirements for reimbursement change. So at this present time, I don't do diabetic shoes anymore, but I will write the prescription for it. You have your extra depth shoes, which you can use those in non-diabetics, but people who have bunions and hammer toes and things like that, where will eventually ulcerate if it continues to rub against the shoe. Custom molded for severe bunions and hammer toes and severe foot pathology, you can use those. You have your AFOs and partial foot prostheses. Like I said, here in Florida, total contact casts does not go over well, and there are not as many people trained to do them, but they do have some prefabricated kits that will make it easy for you to apply one if you are in an area where a patient is willing to wear one. Also, you have your ortho wedges, your crows, and your DH walkers. Assessing for a malignancy is something that is not spoken about as much as it should be. If you have your wound that is there for over 6 months, you definitely want to assess for the possibility of a malignancy. Just take a biopsy and, to rule that out. Now, some people will do those biopsies in the OR. They'll send it down to pathology and have the pathology. If they say that there's malignancy, they will tell you whether the borders you gave them are clear or not. And so that is always an option, but you can do a punch biopsy as well and send that down. You want to look for necrotic tissue. There are going to be different ways and with whether you can remove it or you can't. You want to know if it's ischemic or non-ischemic. If it's ischemic, you're not going to be very aggressive in your sharp debridement. You may want to do enzymatic or autolytic. If it's non-ischemic, you have more room to do surgical debridements. So there are also additional interventions. Diabetes management, making sure that their blood sugars are within a good range, and also selecting your dressings and your nutritional status. And lastly, but mostly important, patient education. Okay, so you have, if you are dealing with pressure ulcers, you have skin moisturizing products. And this is where I said if you have that non-blanchable erythematous skin, you can come in and use a skin moisturizing product along with the dry sterile dressing or something to offload the area. So you can, the different skin moisturizing products you have are antimicrobials, they lower the bacterial count, emollients, they soften the skin, humectants, they attract and hold moisture, and also skin protectants. Now, as far as wound dressings are concerned, there are a few different choices. You have your alginates, which are basically seaweed, and they absorb to the shape of the wound. They absorb about 20 times their weight. You have antimicrobials, which are most of the ones we use in podiatry have silver added to them, and that provides protection from bacterial contamination. You also have collagens, which encourage granulation tissue. You have composites, which compose of 2 or more physically distinct products in one single layer. You also have the contact layers dressing, which is like an adapting. It's just a woven net so that it's not stuck to the wound. You also have foam, which provides a moist, thermal, insulated environment. You have your hydrocolloids, which are occlusive dressings, and they can allow the necrotic wounds to debride autolytically, or they can allow a clean wound to granulate in. And you have things such as Duoderm and Medihoney, which are very popular in podiatry. Hydrogels are also very popular in podiatry. You have things such as Amerigel, Curacol, and they maintain a moist environment and promote granulation tissue. So the dressing selections are based on wound characteristics. You have minimum, moderate, and heavy. So your first characteristic is contamination, whether it's minimum, moderate, or heavy, and there are different choices as to what dressing you would pick based on that. If you have critical colonization, you want to add silver plus any of those dressing, whether it's an alginate, a foam, or a contact layer. And if there's infection present, you want to add basically the same, silver, whether it's with a hydrogel, alginate, or foam, etc. And I know you have a lecture that's coming up on dressing, so I won't go into too much details. Now, once the wound is not healing, using your gels and your primary dressings, you want to go to something that's a little bit more advanced. So that may be using some type of graft, whether it's harvested from one area of the patient's body and put onto another, harvested from a tissue donor, or harvested from an animal. And then there are also ways that these tissues are preserved. They can be processed as far as cleaning through decellularization. That happens in cases of Oasis and Integra. You have cryopreservation, which happens in graphics, and dehydration, which happens in Primetric and Oasis, and Epifix. And all these additional treatment options that happen after your wound is not healing in a matter of weeks to months is going to cost some extra money. So it's always a question of, do you continue to do conservative treatment, which is going to cost a lot of money over the long term, or do you dish out that initial expense that can heal the patient quickly, but is going to be a large expense? So that's usually the negotiation conversation that I have to have with administrators when I want to write for Regranics, or if I want to do platelet-derived gel. In those cases, in some cases, the patients can pay for it themselves, and they are willing to do that if it's a case of limb salvage. If another doctor has told them that they need to have an amputation and they refuse to have the amputation, then they will call me in as a consulting physician, and then I will tell them all the options that I can, provide to them, but they may have to pay out of pocket for them. So you have your live cell therapies like Apligraph and Dermagraph. And the most important thing with these is basically not even the preparation, because you can go to a workshop and learn in 15 minutes how to prepare it, and you can do that in your office. The most important thing is how to document it. So if you do get audited, they will not take the money back, because that $1,000 that you spent to cover for that Apligraph, if you don't have the stickers that are off the specimen placed into the patient's chart with the date and time and the pictures of the wound, then there's always a chance that they will take the money back, and that's something that you don't want. And if you're working in a facility and such, and it's not documented properly, you won't be working there long. Now there's also the human amniotic membrane, and the popular one out that everyone is talking about now is dehydrated Purion, and they use the amnion and chorion membranes to heal the wound. Lastly, you have your negative pressure wound therapy, which is basically a wound vac. It consists of a pump, a drainage system, and a dressing. You set it at 125 millimeters of mercury, and you can use that in the assistance of closing a wound. I have some pictures here. It can be used in acute wounds, it can be used in chronic wounds, but one of the main issues is you don't want to use it in malignancy. So if your wound has been there, I wouldn't even wait the 6 months. If your wound has been there for 3 months, I would biopsy before I put a wound vac on it, because the worst thing that you can do is put a wound vac on a person who has a malignancy and they find a metastasis somewhere. They're going to blame it on your wound vac. So you just want to be careful with that. And then lastly, again, is the clinical pathway that I use. I'll try to make sure you guys get this slide if you're interested. And it's basically where you're assessing the patient, doing history, then you assess the tissue, venous, soft tissue infection, bony infection, assess for pressure, assess for malignancy, necrotic tissue, and then assess for whether they're candidacy for hyperbaric oxygen, diabetes management, and such. And that is the end of my presentation. Thank you very much.
So I have a question.
Okay.
If you want to do a punch biopsy of a chronic wound, do you go to the edge or the center or somewhere between?
I usually go into the center of the wound, and I will send it off to the lab, and the lab will tell me if they need a better specimen. So the most important thing for me with biopsy is picking a lab that is very thorough in their reports, and where the minimum of, where my error is not, they can take a specimen that maybe I've done an error and still give me a good result. I have sent off specimens, nail specimen for example, and it's come back melanoma, and then they call back 2 weeks later and after I sent the patient off for an amputation and said that there was no melanoma there. So, but the patient already had the amputation. So in my experience, you want to pick a reliable lab. I know we have a lab that sponsors podiatry and is very active in our community. But you want to pick a lab that has great results and results that you can work with, and go from there. And if you're at all concerned about it, then I would take the patient to the OR and do the biopsy in the OR and send it down to pathology and have the pathologist tell you when you can leave the OR. So the pathologist will tell you there is no cancer, you can leave, or they will tell you we need more orders, or they will guide you through the biopsy process. And once you're comfortable with that, then you can do it as an outpatient. Any more questions? Yes.
I think you said that you have used surgery with the vascular surgeon, the general surgeon, plastic surgeon. Like, how do you coordinate all that? Like,
Okay, so I didn't include the plastic surgeon, and it's very easy. You have a patient who is admitted to the hospital, and your patient is succumbing. They're not doing very well. So, for instance, I had a patient who was shot, and he was in a wheelchair. So, as he was in a wheelchair, he developed sacral ulcers, lower extremity ulcers, foot ulcers, and ulcers in between his groin on his penis. So that case, and his nutritional status was poor. The infectious disease doctor came in and none of the antibiotics that were selected was working. So he was succumbing to sepsis. So in that case, we knew that we couldn't, and psychologically, when you go in and you tell a person that they're declining and you don't have a way, you don't know how to save them, that is not very good on their psyche. So we could not take him into the OR multiple times. So the general surgeon is my chief, and he came to me, and I told him what needed to be done. The vascular surgeon shared his office with me, so he was willing to work with whatever I wanted. The urologist came in, did the penis, left. So he did not stay in. He did the penis very quickly and left. The orthopedic surgeon was not comfortable doing wounds. So whenever he would get into the operating room, he would start on a wound and then he would yell for me to come in anyway because he just wasn't comfortable. So for the most part, in the facility, people kind of came to me when it comes to the wounds. They knew I was very comfortable with it. So it was not a difficult thing at all. I basically get along with the other doctors. I tell them what I see, I tell them what I think, I listen to their opinions, and I tell them I don't think the patient is going to be able to withstand going into the OR for you and then coming out, going into the OR for me, or me doing this at bedside while you're doing yours in a septic environment, sterile environment. So if you basically can speak with people, they'll understand where you're coming from. If you give them a medical reason why you all should be in the operating room together, they'll understand. Well, I've gone over my time. Thank you guys for your attention, and